Now, for BTK, not intolerant patients, but progressive patients, would you recommend a PI3 kinase inhibitor in that circumstance?
No, I think what's established are BCL2, the venetoclax. That's established to work and has, I think, acceptable durability of response. Those patients respond, I think, about maybe 70–80% of patients, but there's a drop-off over time. So those patients probably also need to be worked up for cell therapy if they come into that situation. But to your question, is there an alternative to the BCL2 antagonists? I think there are no larger data set. There's some real-world data that Anthony Mato was presenting where I think there can be some responses. In my reading of the data, they are short-lived. It's not very effective to use a PI3 kinase inhibitor in a patient who has or is starting to fail to a BTK inhibitor. So the established way would be to go with venetoclax.
Okay, so for intolerance, there are multiple options for therapy, whether it be perhaps a second-generation BTK inhibitor, PI3 kinase inhibitor, or other. For progressive disease to a BTK inhibitor, probably not a good switch to a PI3 combination unless it's maybe with a combination.
Right.
But as a monotherapy, probably not, because the response duration from the data that we have currently is pretty short if you failed a BTKI to go just to a PI3 kinase inhibitor as monotherapy.
Right, but remember, in combination with the BCL2 inhibitor.
That may be a different issue.
I'm not so sure the anti-CD20 combinations add much.
Fair enough.
It's really important to emphasize that.
Fair enough. So what about, are folks using duvelisib as monotherapy in your relapse patients, since that's approved?
So I'll also add to the discussion we just had. I feel that PI3 kinase inhibitors are very active compounds. I think they were our first foray into this whole arena. And unfortunately, there were toxicity issues. But I think we've all seen the data where when you dose interrupt or you dose decrease, you don't necessarily have an inferior outcome. And there could be some argument that we might have had the dose wrong all along, that we might have gone off with maybe a drug holiday or a lower dose in both of those drugs, that using the selecting the DLT model of trials was probably not the right thing to do in this class of drug because of the toxicity and the mechanisms of toxicity. So I haven't given up on PI3 kinase inhibitors.
Well, many of us have been involved in that.
And we've all seen the toxicity, but I think there's two issues here. One is it's a great drug. We need to figure out exactly how to dose it properly, number one. Number two, we also need to know how to manage the toxicities aggressively and before they get into the grade 3s and 4 toxicity that end with the patient being admitted to the hospital with really bad diarrhea. So I think we have to realize both of those. Having said that, unfortunately, right now, the way it stands is that the PI3 kinase inhibitors, both idelalisib or duvelisib, they're fairly similar efficacy and fairly similar toxicity profiles, and they have a small role in the management of our relapsed refractory patients. But I still feel that they are fairly reasonable choices in somebody who may not be a candidate for venetoclax or PI3 kinase inhibitors. And yes, we do know that patients with untreated, young patients with untreated disease should not get these agents in the first-line setting. There is older patient untreated setting data that seems to suggest that they might be okay tolerated. So they might be I shouldn't say well tolerated, but their side effects may not be as bad as you see in younger patients. So I think there's a lot of things that we don't quite understand with PI3 kinase inhibitors. I still feel that that's a perfectly reasonable choice for a lot of our patients who may, because here's the issue. If you have a person failing BTK inhibitors and possibly venetoclax, what do? And if you don't have access to CAR T.
That's a good segue to the next topic.
Yeah, and if you don't have access to CAR T, or if they're not candidates, which a lot of our patients are not candidates for allogeneic transplant,
Yeah.
I mean, what do you do for those patients? Do you go back to chemotherapy? And I don't know if that's the right answer.